Great. Well, good afternoon, everyone. It's my pleasure to introduce Dr. Patricia Haynes, a clinical psychologist and professor in the Department of Health Promotion Sciences at the University of Arizona's Mel and Enid Zuckerman College of Public Health. Dr. Haynes is an internationally recognized expert in sleep health, behavioral medicine, and stress recovery, with a particular focus on how sleep affects mental and physical health in high-stress occupations. Her work integrates clinical psychology, public health, and public health to develop practical interventions to improve resilience, well-being, and performance. She has numerous NIH-funded studies examining sleep interventions in first responders, including firefighters, work that she'll be sharing with us today, and work that was recently recognized by Arizona's Fire Chiefs Association via their President's Choice Award. And it was via this hat that I was fortunate to spend a couple of days with her this summer, as we both served as stakeholders on a committee related to sleep and firefighters initiated by Joel Billings from Embry-Riddle Aeronautical University. Beyond her research, Dr. Haynes is a dedicated educator and mentor, and her translational approach continues to shape how we think about sleep as a cornerstone of health and prevention. And so without further delay, I'm happy to turn the stage to her.
Thank you so much, Nicole. That was such a great introduction. I'm honored to be here today. And today I'll be talking about our SAFFIRE, or our Sleep Assistance for Firefighters project that we are conducting. Currently, it's an implementation project in 20 different agencies in the state of Arizona. So I always like to start thanking my team so much for this work, including a really strong investigator team, staff, a number of my students, and then also our sponsor, which is NHLBI. And then also want to thank our partners for their ongoing participation and their really important insights. We've done our best to use community participatory approaches, really wanting to highlight all of our key partners at our 20 agencies, as well as our community advisory board. And specifically the 100 Club, Rainey Crabtree and Melissa Kowalski, who are really essential. This work couldn't happen without them. And on such a large project with so many different people, different players involved, I always like to start off with a contextual lens of where I'm coming from in conducting this occupational research. I am fortunate to have a long history time working in the VA, where I participated in the original rollout of the CBTI implementation plan. You can see this really cool team led by Rachel Mamber here. And we learned a lot of things about protocol development and training issues involved in implementation that I was able to bring to this project. I also like to let people know, I know there's a lot of different disciplines here, that I'm a licensed clinical psychologist, and my background is actually in trauma, and I'm a certified behavioral sleep medicine specialist. So I've been working a lot of my career, but mostly in health systems. So, you know, in terms of practice for the first half of my career. About 10 years ago, I transitioned over to public health because I really wanted to start exploring sleep as prevention for mental health type issues. And then for the last 10 years, in addition to looking at research and stress-related research, I've been a practicing psychologist for the Tucson Fire Department. And I really just, you know, mostly of my work there is mental health, but I think it's really been important to frame my work and help with kind of this intrinsic understanding I've gotten of the whole, if you build it, will they come phenomena that we definitely face in workplace settings for health programs. Okay. So what am I hoping to do today? What I'd like to do is provide a brief intro to the problem of sleep and healthcare access in the fire service. I won't go too long in there, but then I'll orient you to our SAFFIRE project and hopefully present some early outcomes from phase 1 of the project, which is a formative assessment, trying to look at how we tailor the program so it's most likely to be implemented and updated. Next, I'll just give a brief overview of where we're at currently in our phase 2 effectiveness trial, which is a stepped wedge cluster randomized design. And then in phase 3, I'll be talking about our plans for how we're going to actually evaluate implementation. So, okay, so just briefly overview, probably Dr. Boyles has already given a lot of information, but we all know that firefighters have a lot of sleep disturbances. In fact, up to 42% screen positive for sleep disorders. And the interesting thing is they don't really seem to prioritize recovery sleep. And that's especially concerning because we know that when that insufficient sleep is such a key issue with cardiovascular disease, and that unfortunately cardiac events are the #1 leading cause of death for firefighters on the job. So this is a real concern. In addition, I always like to kind of present this slide talking about how firefighters' sleep problems arise from multi-level determinants, because it's so easy just to talk about the shift, but really when we think about sleep problems, they come from multiple levels. So there are lots of different causes of chronic sleep deficiency. So for instance, you can see that there are undetected sleep disorders, listening for the tones, drinking to sleep, stress-related symptoms, trying too hard to sleep, lots of different issues happening on the individual level. At the interpersonal level, there's poor access to healthcare, poor supervisor support, family priorities. Dr. Bowles has written actually a really great article talking about family tensions that occur because of the shift. I think we need a lot more work in that area. And then also conflict with coworkers. At the organizational level, obviously built environment, shift scheduling, mandatory overtime, high call volume. Some agencies have no occupational health access or a policy where they're not allowed to nap. And then there's also inadequate insurance issues now, with a lot of firefighters opting for less expensive versions that have high deductibles. At the community level, there's a strong legacy in the fire service of 24-hour shifts, and sometimes that's looked at as a sort of a barometer of whether or not people can actually perform their job. And so sometimes these norms develop about placing other people before themselves, along with an expectation of constant availability in EMS. And then finally, in terms of public policy, we know that right now there are no working limits for firefighters, and that's very different from transportation or medical industries. So I always like to just present this slide to say that knowing about the problems in the fire service, there are multiple causes at multiple levels, and it just speaks to how we really need to know the job function and the culture. Okay, brief review. I'm not going to go into too much detail because I suspect that this crowd is already aware that insufficient sleep is such a huge issue for work-related and cognitive problems. But just as a quick review, we know that insufficient sleep causes lots of problems with impaired sustention, memory, and these boxes are highlighted because there's strong meta-analytic support for that. We also know that that insufficient sleep leads to impulsive decision making, and these findings are in gray because there is some research supporting that could be a mixed finding. We know insufficient sleep leads to poor judgment of actual sleepiness, impaired linguistic comprehension, and avoidance of effortful tasks. I really like this work by Mindy Engel-Friedman, who has a whole theory of avoidance around effort related to sleep. And these boxes are in clear because it indicates just one or two studies that support this, but it's a really nice, promising area for more work. And then systematic reviews have supported that insufficient sleep leads to impaired social emotional skills, emotional reactivity, motor vehicle accidents. So pretty solid evidence there. We know that it leads to absenteeism and more employer costs, medical errors, somewhat mixed on medical errors, but some good data on it, but goes both ways. Public complaints and unethical behavior. So those are just work-related cognitive skills. I have a whole different slide I'm not going to present here today on all the health effects of insufficient sleep, but it goes without saying that it's a really serious concern for job function that needs to be taken seriously, as well as safety of others and health of firefighters. Okay, so with that, given that we know, I'd like to now shift to the barriers that firefighters face in terms of getting assistance or help with sleep problems. Okay, so there are a number of barriers to care. So first of all, firefighters work most of the time 24-hour shifts, and I say 24-hour plus because there's actually a trend moving to 48-hour shifts. And one of the things we know is that when people work long hours, it deters them from receiving preventative services. So there's a real suggestion that firefighters perhaps are could be less likely to go in and get those annual physicals or other preventative care. Another barrier to care with firefighters is that 92 to 95% are men, and we know that men are much less likely to use preventative health care. And we're not exactly sure why, but we think it has to do with traditional masculine norms of stoicism that could lead to feelings of shame or avoidance in asking for help. And this pans out with our phase 1 survey, our data. When we asked firefighters who help support healthy habits, you can see that like the largest group, 45% about, indicated that no one does it. They do it themselves. Okay, and then also there is some data. There is some data to show that men delay sleep treatment to prioritize their family, and so so I think that really speaks to the sense of self-reliance that firefighters may have, along with their service mission. Their entire job is about helping their community, helping others, and now even helping their family, often to the detriment of their own health. Okay, so this is where workplace wellness comes in. I think that there's really good, strong potential to end sleep intervention within the place of work. Most work, but one of the things that's really interesting out there is when we look at the research, we know that there's a lot of different workplace wellness programs, but most often they're in the area of nutrition, exercise, stress management, tobacco cessation, or combinations, all of the above. And they're like much fewer comparatively on sleep specifically. But several studies have employed sleep health promotion in the workplace. I just want to say that most often, and they do not include the effective ingredients. So this meta-analysis by Robbins and colleagues looks at the type of intervention workplace wellness, and you can see these are typically interventions that people talk about when they talk about sleep health promotion. But of all these interventions, only cognitive behavioral therapy for insomnia, this gray, is considered evidence-based or sufficient to make lasting change for sleep. Now, in addition to only having a few studies that look at CBTI in the workplace or CBTI ingredients in the workplace, you then add in the examples that there are a few examples in first responders or even shift workers in general. Obviously there's some really great work done by this group with Carrie Coles, Diane Elliott. I just want to acknowledge are some of among those great examples. But in general, overall, we're kind of behind on the field in terms of targeting like effective ingredients for sleep. So that's where SAFFIRE comes in. So the goal of this project is to address the barriers through sleep health workplace wellness programs. So address the barriers to sleep healthcare access through workplace wellness. Okay, so we're using a hybrid one design. Just a friendly reminder that means there's an effectiveness trial that tends to take priority over implementation, but we're looking at implementation in a very detailed, almost like accounting way through the trial, so we can develop and form later hybrid 2 and hybrid 3 trials where implementation is more of a focus. The study is for 5 years and it's across 20 agencies in Arizona, and we're looking at 400 career firefighters. There are 3 study phases. The first phase, which I'll be talking a little bit more about today, is our cross-sectional survey, followed up by qualitative data on how, and we wanted to ask the question of how can we tailor the evidence-based behavioral sleep program that we're developing to the fire service so that we can be sure that it's implemented, so we can foster uptake. The second aim is, does the program work? So the program consists of sleep coaching, personalized sleep coaching that's based on, the delivery is based on firefighters' needs. It's all remote through Zoom, and the session length is highly variable, and we have strict definitions of what a completer would be. The coaching's done by paraprofessionals that we are also working on training in conjunction with the 100 Club of Arizona. The other part of the program is a sleep leadership training, asynchronous training program that hooks into learning management teams, and those are administered together. And that one's for managers. The third aim of the project is, what are the factors that lead to agency uptake? So we're looking across the 20 different agencies and looking at combinations of implementation factors to see if we can, to try to inform future work. Okay, so I thought I'd start off with just kind of going through our implementation framework and talking a little bit about what we've learned on implementation. We find it pretty exciting and want to share as much as possible. So we administered a survey to identify implementation facilitators and barriers, and 373 people who started the survey across 20 agencies in Arizona. And you can see that the statistics and the demographics largely fit the demographics of the fire service, mostly male, mostly white. 17% of our sample is Hispanic. 44% of our samples managers, which is captain rank or above. And captains are oftentimes the rank that usually the rank that oversees the crew. And then you have different levels of chiefs above captain. 93% of our sample were 24 hours or longer, which means 93% were in the field, and then approximately 57% were married. Okay. For our framework for this study, we chose most of our measures based on the IPARIS framework. IPARIS stands for Integrated Promoting Action on Research Implementation in Health Services. So this is a framework by Helfrich and colleagues, and actually they're the ones that came up with the measure. And why did we choose the IPARIS? Well, we felt like facilitation, which IPARIS focuses so strongly on, was really key for our population. So facilitation is this process of interactive problem solving and support that a person gives within a context to help improve and support things. So in the fire service, many people have someone called like a health and safety officer or a health and safety captain or a chief, and that is a role that strongly suggests that one-on-one contact, that facilitation is really key. So as part of our framework, we've required that every agency provide what we call an internal facilitator, or an IF, that is the person that is doing a couple things, and then we as external facilitators, study team, train the internal facilitator on certain skills. Okay, so according to this framework, we train them on team and process skills, influencing, negotiating, project management. So we give them all of this information. And then what we ask them to focus on is the recipients in the organization, the innovation itself, which is our sleep coaching program, the local context, and then also with the knowledge of the organizational context and the external context. Because they're internally located, they're in the best position to understand how their agency works within the broader scope of the socioecological model. And then they give us really good, solid information back and forth so that we can tailor the program for their agency and community. Okay, so the reason I mentioned IPARIS at this point in the talk is because it framed most of the measures that we chose as part of our phase 1 survey. And in particular, something that's really cool about IPARIS is that it has a really nice measure for organizational readiness to change. They call it the ORCA, which is the measure developed by Helfrich and colleagues. And from that, we can look at innovation recipients, context, and facilitation to see and understand where each agency is at in order to tailor the program. All right, so with that in mind, this theory in mind, I'd like to present some results, kind of going through each level of the IPARIS model, kind of showing you just really some basic summary statistics of what we've learned about implementation through facilitation and barriers. Okay, so we'll start with inner context and the organization. Okay, so one of the first things that really surprised us, actually, because we thought it was, it would be such a big barrier, is actually we found the inner context at the organizational level as a facilitator. We found very minimal stigma around sleep coaching. In fact, more than 80% of people agreed that if they received sleep coaching or they knew of someone getting sleep coaching, it would not hurt their chances of getting promoted. It would not lead to concerns about fitness for duty. It would not lead to less confidence. They would not be treated differently. They would not be seen as weak, inadequate, or less intelligence. In fact, 76% report that leaders would encourage them to get sleep coaching, and 82% reported that crew members would encourage sleep coaching. So the take-home point with this facilitator is that there is already substantial support. These agencies are ready to go from an organizational level, and there's minimal stigma, and that both field and personnel and leadership are supportive. So that was really promising. Now, in terms of so now let's talk a little bit about the local context and what we learned there. Sorry. All right, so this is work done by my grad student, Matt Lujan, who wanted to look at local context by looking specifically at non-managers who would be eligible for the coaching program. So people with moderate or higher sleep disturbances, and it was a subset of our sample of about 145. And we went through and asked them, like, we looked at the acceptability, how acceptable people rated the program. That would be on the y-axis. And then we asked them what they felt like in terms of their opinion leaders. How ready for change are their opinion leaders? And opinion leaders were defined as labor leaders, as well as potential health and safety officers, what we would call their IFs, their internal facilitators, people that are promoting health and wellness initiatives. And you can see that those people that had those agencies and those people who perceived their opinion leaders as being ready for change, as ready for something new, had high program acceptability, whereas those who felt like their opinion leaders didn't really seem to care about health or whatever, the acceptability was pretty low. And this was a highly significant finding, and perhaps not that surprising until you start to look at the next finding we found, which was more of a barrier related to local context, which is now we're looking at perceptions of senior leadership. Like, what is the culture like with senior leadership? And again, y-axis is still program acceptability. And what we found is that those agencies where they perceived senior leadership as having a high supportive culture, what's interesting is that acceptability was actually lower as compared to agencies where they had low supportive senior leadership support. They then looked at the program as very acceptable. Okay, so it was a completely opposite direction than what you would anticipate with managers. And so we interpreted this. I mean, it took us a while to go, what's going on, right? But we interpret this as a potential boomerang effect. So if managers are out there saying, hey, let's go for health, then the idea is, but specifically and potentially because of labor management disputes or whatever is happening in that agency, sometimes managers, it might actually just boomerang around, and people might be a little bit more suspicious of the program if it's super highly endorsed. So how does that inform implementation? Well, what we felt like is that it's really just important to know the local context. So it supports our use of internal facilitators, again, most often those health and safety captains. But we've actually had to gently discourage involvement of senior leadership as internal facilitators. So once in a while, we'll get a smaller agency where the senior leader, the fire chief or very high-ranking chief wants to be the person to disseminate. And we try to gently discourage that. We want their support, but we want it in a different way. The other thing that we really stressed is that we've encouraged our IFs, our internal facilitators, to involve labor as a part of their implementation team. And so once in a while, when we get into that labor management dispute area, what we do, where labor's like, well, management likes this, maybe we need to be a little sus about this program. We've actually have our state level union representative. So there's a state level union on our community advisory board who then reaches out to local labor and tries to help explain. And he's just been an amazing advocate. So it sort of speaks to how we need to use our community advisory board and how key it is in helping overcome some of these barriers. Okay, so now we've talked about inner context for organization. We've talked about inner context for local. Now let's talk a little bit about what we've learned about the barriers and facilitators when it comes to recipients. Okay, so first of all, this is one of the places where we found some of the most barriers. And in particular, just looking at some of our summary data, we asked recipients, people that might benefit from the intervention, do you think that sleep coaching works? And we gave them a lot of information, like kind of describing what sleep coaching was and supporting the evidence base. And you can see that only 27% of firefighters agreed and 72% either neither agreed nor disagreed. So they didn't disagree, but they're skeptical, okay? And we were really interested in this. We're like, why is this? We've explained it's an evidence-based intervention. We've explained it's been used successfully for people with insomnia and shift work disorder. It's been based on military models, which is a very similar population. It's tailored to the fire service. All our coaches are trained by experts. We're using best practices and participatory research. Like why so suspicious? Why uncertain? So we took this question again to our IFs and to our community advisory board, our partners, and I loved the answer they gave, which is that they don't feel like it's going to make any difference because of the shift. So whether it makes a difference or not, it doesn't matter. They feel hopeless. Okay, so we went back to our data to see if this could indeed be the case. And we said, do firefighters feel hopeless about their sleep? And again, we asked them this through this question, do I believe I have control over my sleep? And you can see that it's kind of a double negative, but this is the belief I have control. So if you disagree, it means I do not have control. And if you add the 47% with the 26%, you can see 76% of people, in effect, do not believe they have control. And then we said, why? 94% agreed that work affects when and how much I sleep. So in a nutshell, firefighters are feeling pretty hopeless about the possibility of even changing their sleep. So how did this inform our implementation and our rollout? How does it inform how we're still implementing and trying to roll out? Well, first of all, now instead of going in and being like, hey, here's this great sleep program, it's going to really improve your sleep, we actually use more of a harm reduction perspective to engage the sleep behavior. So we always start with, there are so many elements of the sleep that are outside of your control, like being on call outs, being the shift. We acknowledge that. Our goal with the sleep program is to reduce the negative impact of the shift on your sleep through things that are within your control. So we talk a little bit about influences of control, rather than talking about an expectation that it would ever get to the same level of sleep as somebody on a 9-to-5 shift, for instance. The other thing we've done to inform implementation is try to use support networks to market elements that are within control. So we really focus on talking about the intervention in terms of, for instance, one of our interventions is recovery sleep and sleep timing. So we always say, like, hey, when you went through academy, did you ever learn like when to sleep and how to handle the shift? And most of them kind of look at you, and then we're like, well, how did you learn? And they're like, oh, just I asked my captain what he thought, like how does he handle it? So we're like, well, here we are, and we're going to give you some solid recommendations since the shift is not ending anytime soon. Let's give you some solid recommendations about that might work for you and your family. Okay, the other ways we've marketed elements are sleep extension, returning to sleep after call outs, napping, caffeine timing of ambient light exposure, and then standard CBTI. All these elements are within each individual's person's control. And so we try to remind them of that rather than, because the focus tends to be like, well, how are you going to reduce the number of calls? And of course, we can't do that. The other thing we did to inform our implementation is we renamed this from sleep coaching to sleep fitness. And this was based on the recommendations of our internal facilitators because they have peer fitness already. They have peer support. So they felt like sleep fitness kind of speaks to overall sleep health and well-being rather than like coaching, which they felt was confusing in terms of what it meant. Okay, so we've talked about context, we've talked about recipients, and then finally, I wanted to share some results of what we found about implementation facilitators and barriers based on innovation. Okay, so the innovation, again, is the sleep program. So the good news is that we found that all the interventions that we are administering currently are perceived as acceptable by the majority of the respondents. And you can see the order in which they found them acceptable, with sleep education being the most acceptable and exposure to light and darkness being the least acceptable. Okay. And I just want to stop for a minute and acknowledge this was analysis that was presented at the sleep meeting by my postdoctoral fellow, Josie Wei. So we were interested in the ordering of these results because, for instance, one of the things we know is that sleep education is the least likely to create behavior change. So we find that they're most interested in that in terms of acceptability. And so we started trying to figure out why they thought that would be key. And we don't have the answers to that, but we find it interesting, and it sort of influences, we've given this information to our coaches as well. Interestingly, sleep education is also rated as highly effortful. It's one of the second most interventions that's perceived as effortful, which is interesting because, again, it doesn't require behavior change. I want to look at recovery sleep enhancement, which is the second most preferred or acceptable treatment. And again, 66% of it rated it as effective. I think people believe it's going to work, and that has the highest rating. And it was also rated the highest on affective liking. So 74% of people just liked the idea of knowing when they could do recovery sleep and how they could enhance it. The third intervention, the third most acceptable intervention, was sleep effort reduction. So this is a cognitive intervention where people, we give input on how to talk back to thoughts when people find themselves trying to will themselves to sleep. And one possibility is they do not rate this as effortful. So 20% rated this as effortful. So people thought that this would be an easier intervention, which is interesting. And then finally, sleep lengthening, which is also, we call it sleep lengthening, but it's actually sleep extension. And we found that this was rated 69% liked the intervention, which was the second highest rating. 63% rated it as effective, again, second highest. And it was actually rated the most effortful intervention, which is 35%. So that kind of tells you that there's a lot of barriers that go into people trying to extend their sleep, or that's what they perceive. Let's talk about a barrier with innovation, that in addition to, we had that facilitator that people find most of the interventions were administering acceptable, excuse me. But a barrier that was expressed was the cultural competence of the interventionists. So we asked people, do you think sleep coaches are unlikely to understand the fire service? How much do you agree with this statement? And again, when we put it together, 58% of people, 20% agreed, and 38% neither agreed nor disagreed. So again, they're suspicious about whether or not people are going to get the fire service. So how does that inform our implementation? Well, what we found is that we had to choose culturally competent coaches for this to fly. So I want to just acknowledge on the slide that we do a lot of training in this. People take pretty much a 4-credit unit course through the U of A on sleep health coaching. So they get the science, they get ethics, because again, this is paraprofessionals. But we videotape them coaching, we rate their skills, licensed clinical behavioral sleep psychology experts rate the skills. So we do a lot of work just like we would do in any rollout. But what was really key for us is making sure people are culturally competent. So we have the 100 Club of Arizona choose the people. They get to decide who's there. And we actually let them hire the coaches so that there's buy-in through the state agency that really serves firefighters. And so to date, most of our coaches are current firefighters looking for extra work. They're retired firefighters, or they're family members of firefighters. We only have two students from the University of Arizona that probably don't have as much, but even those students are required to do a minimum of 4 hours ride along, and they're trained and quizzed on shift and shift demand. So we spend a lot of time making sure that there's cultural competency among our sleep coaches. Okay, so now I thought I'd just spend a time just to review our process, because I think it's been really key for us in terms of implementing this implementation science project. Is we've gotten a lot of input on the formative survey from our partners. Not only did we take stuff from the ORCA and from IPARIS, but we asked people if the surveys looked appropriate, if these beliefs seemed to feed into the target areas. We monitored and we shared our aggregated survey responses. So we took our data back to our community partners and asked them what they thought. And then we described our facilitators and our barriers, the implementation barriers, in terms of the model, the theoretical model, which is context, recipient, and innovation. We listened. Sometimes I didn't want to, but we listened because I'm like, I disagree. But no, they're always right. We listened to our internal facilitators, and they participated in data interpretation. I feel like that was really important. We queried our partners about solutions. Sometimes they're like, this doesn't work, but we always had to ask, okay, so what would work, We're moving into phase 2 now to use what we learned, and we're pretty much repeating the process. And our stepped wedge randomized controlled trial began, we started recruitment in October, and we did the first rollout of the first wave over the summer. Okay, so let's talk a little bit about the second study phase and what we're doing now. Okay, so here's our design. So you can see this is our step wedge design. Currently, we're in the middle of looking at clusters 1 through 5 agencies. They're right in the middle of the intensive intervention, and then they go into the sustainability intervention. And about 6 months later, we go into our next cluster. Everybody, there are 6 assessments over the course of 3 years, and each assessment period lasts about 1 month. We actually have it's hard to see on this graphic, but we have a little transition period for people as they transition from one phase to another. This is an open cohort trial, so it's okay for people to retire. We just kind of replace them with somebody else from that organization, ideally. Our outcomes, our primary outcome is the PROMIS Sleep Disturbance Index, and then we are attempting to administer actigraphy. It's definitely a feasibility challenge in 400 people at one time. But I think we're going to have a good subsample enough to look at that. And our main outcome is a multidimensional sleep health composite. Our secondary outcomes are the sleep-related impairment index and sleep continuity from the actigraph. And then tertiary, we're looking at cardiovascular risk factors, including blood pressure and heart rate. And then we have a number of moderators here that we think could have potential chance to moderate our outcomes. It's a multi-level intervention. I think I mentioned this before. We're getting this individualized sleep coaching. We use the CBTI VA manual as a bouncing off point. Obviously, we had to really kind of break things up in terms of sleep efficiency training to look at sleep strengthening and sleep lengthening separately, because some people just need sleep extension. Our manager training is based on the sleep leadership training in the military through the Department of Defense. And then we have our training that we've provided for internal facilitators is based on the VA and the query manual. And I just say we expanded that because that manual is relatively exploratory. Thought I'd just share a couple delivery decisions that we've made over time. So first of all, anytime we're faced with what do we do here? We've actually really used the post-grant sustainability as something that guides our resource decisions. So for instance, we've intentionally used the CBTI Coach app instead of developing our own app, because we know that once the project ends, it's going to be hard to sustain that. But the CBTI app through the government right now remains free and accessible. We also use the CBTI manual through the government. So again, anytime we're tempted to kind of go in and create something, we try to use what's already there. These paraprofessional interventions, like I said already, they're chosen by this first responder organization that could potentially maintain employment through donations in the community, delivered by coaches with cultural competency. We use remote modality. We feel like firefighters really like one-on-one, except when they're tired of driving. So actually remote modality has been well accepted by them. And the other reason is they can do it on shift during downtimes, especially at agencies that support them. And we really pushed hard for agencies to support them on that. And most agencies do. I remember our NIH reviewers really wanted us to administer legacy scales that could potentially relate to sleep disorder diagnoses, but we pushed back, feeling like potential fitness for duty concerns might not be an issue now, but it could be an issue later. So we really use multidimensional sleep health instead. And then finally, we administer the coaching based on a personal plan based on their goals. So we really use a coaching model, and it's a 2-session minimum and a 12-session maximum. So people kind of get to think of it like a menu that you work on with your coach, and they kind of figure out what interventions would be best for your issues and given the amount of time and energy you have to commit to the process. So we make it as flexible as possible. So we use case conceptualization through a scale called Are You Sated, which is it stands for the regularity, sleep quality, alertness, sleep timing, sleep efficiency, and sleep duration. So we consider all of those. Coaches conceptualize their cases on the socio-ecological model, so looking at biological, behavioral, and social determinants of sleep. And then they link the problem to the proposed intervention. So if they have a certain determinant, like we're just reviewing videotape of someone who uses chewing tobacco all day long, that would be a good example of a wake-related behavioral determinant. And so then we link that to sleep education, which would be an intervention that would link to that specific issue. And so here's an example of how we use intervention mapping. So if a person, for instance, that person I just mentioned is having a problem, they're actually having a problem with sleep status, you know, in some ways their lifestyle education would fall up here under all. But if a person's having a major problem with sleep efficiency, we encourage coaches to start with stimulus control and then maybe go to sleep strengthening, which is a form of sleep efficiency or sleep restriction, and then sleep effort. So sort of the order of the intervention starts on top, but that's allowable with any form of rationale. How do we train interventionists? We use our U of A continuing education, and we're pretty much building a state workforce with people that are interested. A lot of agencies want internal, not a lot, a few agencies want internal coaches, but some want to use external coaches. We let them have whatever they want, and we're going to be looking at that as a factor at the end. Every coach is required, like I said, to do ethics training. The second module is on just sleep knowledge, and then the final knowledge is sleep practice, which requires videotape review and fidelity ratings. Our sleep leadership training has 2 modules, again, very similar. Sleep 101, which is about just sort of essential sleep knowledge, multi-level contributions to sleep in the fire service. And then Sleep 2 is sleep leadership, where they promote pro-sleep leadership behaviors. They're looking at role modeling and also demonstrating practical strategies to improve sleep crew health. So we talk a lot about like pro-napping, like alertness levels, ways to have conversations around sleep. And we talk a lot about the concept of sleep devaluation. And except we flip it, we talk more about how do you value sleep. And then we even talk about in sleep leadership about long-term, like how do you change, how can you develop community approaches, for instance, for frequent callers that are happening in the middle of the night to perhaps change long-term over-reliance on EMS, which I think is part of the sleep-related issue as well. As part of this training, we've had 4 fire service experts give us feedback, 2 through really detailed talk-throughs as they're taking it. What do you think? And then we've had 2 read-throughs as well. Okay, last set of slides. Hopefully there'll be some time for discussion. So what are the factors that lead to agency uptake of the program? So obviously we're not there yet, but I just want to talk about how we plan to evaluate implementation. So our primary agency level outcome is adoption. So how many people within the agency actually chose to use the sleep program. And our secondary outcomes are we able to have implementation fidelity? Is the program acceptable? And then how much our stakeholders perceive the program as useful. And how are we going to do this with only 20 agencies, right? Like you don't use, so I use fuzzy set qualitative comparative analysis quite a bit, where you can analyze set theoretical relationships between various combinations of agency level factors. So it's a really nice way to build theory and to look, because I always find agency level analysis difficult because it's just hard to have the number of agencies you need. Okay, so in summary, what have we talked about today? So our goal with the SAFFIRE project is to enhance the feasibility or the accessibility of evidence-based sleep intervention by expanding it to a workplace setting. We want to improve the sleep of firefighters. Our goals with this project is not only to improve sleep, but to cultivate a sleep supportive culture in the fire service. So we've talked a lot about sleep valuation. We want to determine which firefighters are most likely to benefit from the evidence-based sleep intervention. So we look at a number of moderators and like what's going to be framing this real life pragmatic trial. We want to understand which agencies are most likely to benefit from evidence-based sleep intervention. So when are agencies ready for these resources when they come? We want to help agencies learn how to implement. So we're not, what we've found is that most agencies are already trying to implement peer support programs, peer fitness programs, but sometimes they go stale. So we're going to, hopefully that what we're learning here, they can use in their other programs as well. And then finally, our goal is to advance our understanding of IPARIS framework for workplace wellness in general. It's a really nice framework for use with facilitation. For some reason, REAIM is great, it takes off, but REACH, but for some reason, IPARIS seems really well tuned into workplace setting in particular. And I think I'll go ahead and pause now and see if there are any questions or what the next step is.
Thanks, Trisha. That was awesome. If anyone has questions, please, you can just raise your hand and I can call on you. And I wanted to highlight that I noted, apart from our own faculty, I saw that Matt Lass out of the Oregon Fire Marshal's office is here, and he leads the Oregon Fire Service Health and Safety Collaborative.
Oh, cool.
Not seeing any hands at the moment, I don't think. And so perhaps while we're waiting for some questions, I had one going back a few slides where you ranked, I guess it was the perceived barriers, and one that was higher, like it was the lowest on the list, was the exposure to light and dark, which I was I guess I was surprised about, because it seems like it's a passive thing. So if that was something that could be manipulated, to me, that would be something that people would go for. So do you have any understanding of why that was ranked so low?
Yeah, I wish we'd asked like why, but I think there was like survey fatigue at a certain point. I think that my perception is that people may feel as though like wearing glasses, or if you think about it, they get up, and a lot of the shift changes right now in Arizona are still in the morning. Like there are a couple of agencies that have a little bit later shift changes, and I think there's a perception that they're kind of waiting around for their crew, like their relief, to come in, and like there'd be no way they'd be waiting around with sunglasses on. That would just be like kind of socially weird, right? So I think that things like that kind of need to be ferreted out, but I suspect that's it, because it's really, that intervention is really just about trying to control blue light exposure in the morning, and then also thinking about light exposure if you're going home to nap and what that means. So yeah, it was a little weird, but I think that a lot of it could be social.
Amelie, go ahead. You can go ahead and unmute yourself.
Hi, my name is Amala Salminath. I work with botanical remedies, botanical products, and thank you for a really great talk. So my question was, I know this is not the focus of your work, but do you have a way of monitoring what kind of supplements, be it melatonin, et cetera, some of the firefighters are taking to address their sleep issues? And is that something that you would consider in the future, maybe as being one of the interventions, if we can get the right evidence for it?
Yeah, actually, there's a strong formulary that firefighters aren't allowed to take because of the job. So melatonin is actually on for most of the agencies in Arizona. Melatonin is kind of like not allowed because it could potentially cause sleepiness on shift. So if you're taking melatonin, it's on off shifts, but then it's sort of a question of you kind of have to disclose it to occupational health, and it becomes a number of things. So I think a lot of times there's not as much interest in doing that. We do give education to sleep leaders on melatonin and like on over-the-counter supplements, but a lot of it is about, I think there's some misunderstandings about how those are administered and how they affect the body. So a lot of, we stand very behind lots of evidence base. So we try to talk about things they need to consider when they hear people talking about things that there isn't a great evidence base behind. So.
Yeah, of course, and I agree. There's not a lot of evidence behind a lot of these products, but it'd be interesting to see if people are using them. I appreciate that there's some that they can't use because of the restrictions on them.
Yeah.
But anyway, thank you. Really interesting talk.
Thank you.
Then Krista, do you want to go ahead? I can get you started. Do you use the actigraphy data as part of your intervention as well, in terms of giving feedback and guidance based on output?
Yeah, that's a great question, and we went through that a lot. We actually don't, and we didn't administer Fitbit for this reason, because again, sustainability guides our decision. We want to see if the intervention would do well on its own. So coaches are trained to administer sleep diaries as part of the intervention. But if people want to use their own Apple Watch or their own devices, even though we explain to them that, there's questionable validity sometimes. Whatever they're going to use when they're done with the study is what we want them to use. So we're like, send us in that if you don't want to on your personal devices, and we can work with that. So coaches go back and forth with people in terms of giving them feedback as part of the program. But as part of the project itself, like when they wear that actigraph, we don't give those data back. Yeah, we really, because that could cause behavioral change, and we don't want, we want this, again, the intervention to stand on its own.
Great, that makes sense. Sorry, I can now unmute myself. That's great. And then a quick follow-up question. So we did a similar study with the National Guard several years ago, and doing a leadership training as well as individual feedback. Do you plan on trying to parse out the effects of each of those intervention components? We've had some difficulty doing that, so I'm curious.
Yeah, right. Exactly. I don't, we might be able to do it because we're a little bit delayed in the first wedge and getting the leadership training out. So we might be able to do it a little bit, which kind of, is one of the things I'm finding with implementation is that you kind of have to let go of control a little bit and call them adaptations and kind of look at them as they occur. So there's a little bit of a delay in getting our leadership training out to the first wedge, which is going to be an adaptation we could potentially look at that question with. But yeah, other than that, we don't see a feasible way to separate the two because they're constantly interactive, right? Like as we find that people go in like, oh man, I had this great session with the sleep coach, and then the leader goes and gets information, and then they come back, and so I don't think there's any way to separate it that on this type of scale, on this type of study. But I'm always open to ideas.
Got it. Yeah. No, that's great. And I think it's so important to have both of those components and come at it and not just have the onus be on the individual to like improve sleep and but have a supportive cultural context for it.
100% agree. 100% agree.
In your initial survey, were you intending to have such a large or portion be managers? It was like 44% were managers.
Yeah, no, we weren't, but yeah, and it's interesting that managers could be overrepresented for sure. We weren't intending, we kind of opened it up to whoever. So that could skew the data for sure. I mean, the one thing though about managers is that a lot of them are still in the field, and they still have manager, so I think that we had a lot more captains respond than we anticipated. But in some ways, yeah, it's not ideal for representative, but in some ways we find that captains have the most influence over their crews. So having them respond was another like recruitment strategy to help get more people underneath them to respond.
Are there any other questions?
Yeah, I have a question. It's Steve Shea here. Thank you for a wonderful presentation. It's such a comprehensive program. I really have two questions. One is, did you ever consider having a control group without any intervention? And I know that they're staggered. Maybe you can tell us how you're going to analyze the effect.
Yeah. Dr. Shea, thank you so much for attending this talk. It's great. I know you've done some really good work in this area as well. So we did consider, we thought a lot about a randomized cluster trial, but you saw, like I kept saying, they're kind of sus, right? Like, so we found that even just the 2-year waiting period for people has been a major obstacle, even though, and if they felt like they were not going to get this or even have to wait longer, or if they're in a control condition, we felt like there's substantial research mistrust in this community, that it was actually really important to explain up front, like how we're randomizing. So the StepWebs trial really seemed that, and just the rollout itself, it seemed most feasible for this population. So we know there are major limitations with StepWebs cluster trials, but I'm not sure there would be another way of looking at it with this group and having the people participate that have. It's interesting, we really have faced, even with this project, a lot of research mistrust. So that community advisory board's been helpful. In terms of analyzing the data, I'm sure that is a much larger topic area all in of itself. But we'll be using generalized estimating equations, working really closely with our statistician who has expertise in stepped wedge cluster randomized trials. And our goal is to look at between as well as within effects. So that's that thing that's really good with this trial design in particular.
Okay, and I had to step away for 5 minutes. I may have missed some of the outcomes, but what are your principal outcomes? Are they subjective? Are there any health outcomes that you're looking at?
Yeah, so primary outcome is subjective, the PROMIS SD. Secondary is the PROMIS SRI. Tertiary is cardiovascular. So we're getting their occupational health records for BMI and other things like lab reports we can, because most of them are required to do annual occupational health physicals, plus we're administering heart rate and blood pressure.
Okay, great.
Yeah, I thought you were interested in that. Yeah.
Thank you.
David, I see you have a question, but I'm gonna squeeze in another quick one. For the PROMIS, you're using it like directly as it's laid out. You're not like modifying it to see like, what is sleep on shift versus like what is sleep off shift and how that's changing. It's just, like what is sleep over the last 7 days.
Yeah, we're generally, because it's like perception and sleep quality. And if they go to their shift, they go to their shift. I also feel like it's really just hard to parse out like one versus the other. I mean, a lot of times people talk about firefighters as just shift workers, but their shift is in some ways a little more like physicians, right? They're more on call. So, being on shift at a slow station doesn't necessarily mean that it's going to be poor sleep, right? So we decided that would be too onerous for them and said sleep quality is what it is. It's perception of their sleep. So we'll go with that.
David, do you want to unmute yourself?
Yeah, my question is, thank you, and great talk. It's actually follow up on Steve's points and your previous answer that step wedge trials design have a lot of issues and challenges. So how are you planning to collect continuous baselines for those clusters assigned to the intervention later stages?
Yeah, I mean, everybody gets the assessment every 6 months. Does that answer your question? So
yeah,
that's a continuous baseline.
And it's the same assessment, and then when it's their turn, you do the rest.
What do you mean? And when it's their turn, they do I can go back to the.
Yeah, because the reason I'm asking is because I rarely see this type of designs for workplace studies, and I think people are reluctant because of the, you have to make sure that the baseline, the multiple baselines are standardized, right? Yeah. Until it's time for that cluster to be randomly assigned or to start intervention. So, yeah, I'm just curious about how you plan to implement that design in this context.
Yeah, I mean, and I apologize if I'm not answering your question. But we administer the same standardized assessment at every time point to every person. And so there is the potential for dropout. Is that what you mean, like attrition?
Yeah, I think that would be
so far so good with dropout. We haven't had too many people dropping out, for instance. Do you have another question about the standardization of baseline?
No, I think that's.
Yeah. I mean, that's the hardest part is like the 400 all within a month period of time, right? So you're right. That is very challenging. Correct.
Thank you.
Sure.
We're at 1. Thank you again, Dr. Haynes, for taking your time, or taking the time to come speak with us. And I look forward to the outcomes of this very comprehensive study.
Yeah, thank you both. Thank you all so much for coming. I really appreciate it. It's a pleasure and an honor to speak with you today. Yeah.
Yeah. Thank you. Good luck with the study.
Thank you. Bye-bye.
Bye.